Welcome, everyone. We're glad you're here. I'm Dr. Jessica Seaman, Assistant Dean for Faculty Development in Creighton's School of Medicine. Thank you for joining us for our Health Sciences Professional Development Physician Wellbeing, featuring Dr. Gerald Perman. Just a few housekeeping items before we have Dr. Joe Ranga introduce our speaker. This session is being recorded and you will have access to the recording and slide presentation for future reference. We invite you to ask live questions or submit them in the chat, and we'll get to as many as we can by the end of the session. For those on Zoom, we ask that you remain muted with video off unless asking a live question to assist us with the recording. Also, this session is eligible for CE credit, and you'll receive the website and activity code before we conclude. There is a very short survey. I think it's 3 questions associated with the continuing education, and we thank you in advance for providing feedback as we continue to bring you diverse and robust programming here at Creighton. Now, it's my pleasure to turn the time over to Dr. Ranga, Program Director for the Department of Psychiatry in Creighton University. She will introduce our speaker.
So much, Dr. Seaman. It is my privilege and honor to introduce today's speaker, Dr. Gerald Perman. He is a clinical professor of psychiatry at the George Washington University Medical Center, Department of Psychiatry and Behavioral Health in Washington, D.C. Recently relocated from the Washington, D.C. area to Beverly Hills, California, where he conducts his practice of telepsychiatry from his home office. Dr. Perman is at Creighton Medical School for a 3-day consultation to the Department of Psychiatry as a Teichner Scholar of the American Academy of Psychodynamic Psychiatry and Psychoanalysis. Dr. Perman is the editor of the quarterly online psychiatric magazine, Capital Psychiatry, for the Washington Psychiatric Society, and he is a member of the D.C. Medical Society Physician Health Committee. As a member of the D.C. Physician Health Committee, Dr. Perman meets monthly with other members of the committee to evaluate, make treatment recommendations for, and to monitor impaired physicians referred to the committee. Prior to the pandemic, Dr. Perman gave an annual invited lecture for 10 years, Georgetown University post-baccalaureate class of pre-medical students in Washington, D.C. on physician impairment and well-being. Please join me in welcoming Dr. Perman, who will be speaking to us today on practice of medicine, well-being, burnout, and self-care. Thank you very much, and without further delay, off to Dr. Perman.
Thank you, Dr. Ranga, for your kind and warm introduction. I'm so happy to be here today. I'm glad that you all are here with me. If anybody can't hear what I'm saying, let us know, and we'll try to fix any glitches that we find and come across. So I'm going to be speaking on physician well-being, the practice of medicine, burnout, and self-care. And pretty much the title of my talk is going to be the outline for today. So that'll be it. And let me see here. Okay, thank you, Creighton. I look forward to a robust discussion after my PowerPoint presentation. You've already heard the bottom there of that slide. I'll just tell you a little bit about myself and how I got here. I had my undergraduate education at University of Maryland, receiving a bachelor degree in psychology in 1971 and one in biochemistry the next year in 1972, having not gotten into a U.S. medical school after that. Because my Spanish grades were so poor, I decided I'd try to do it in French. So studied French for a number of weeks in France and applied to it and was accepted into the Free University of Brussels Faculty of Medicine, where I studied medicine for 3 years. And after that, I took some exam that allowed me to transfer into third year at the University of Maryland Medical School in Baltimore, where I received my medical degree back in the day. I then did a psychiatry residency at George Washington University Medical Center, 4 years. And then for the first couple of years, worked at a community mental health center half-time, started my private practice, and then I've been in private practice pretty much for the next 40 years. And in Beverly Hills, I work 4 days a week seeing patients in telepsychiatry, most of them on the East Coast where I still have medical licenses. I supervise, so I've been a clinical professor at GW, moving up through the ranks, and currently supervise a psychiatric resident once a week online. Been a member of the Physician Health Committee of the DC Medical Society for a while. I edit Capital Psychiatry, and I solicit articles, essays, and poetry for the magazine. And Dr. Ranga and others at Creighton saw some of my solicitations to the American Psychiatric Association, and she just liked the tone of my solicitations and got a hold of me to come here. And this is my third and last day at Creighton, and I love it so much. People have been so unbelievably welcoming and hospitable to me. I can't thank them enough. Going to move on from there. And here we go. Yes. So I'm going to start off talking about some of the benefits of practicing medicine. Maybe we have some medical students listening in addition to residents and fellows. And I believe I'm speaking to the Department of Psychiatry and Internal Medicine, maybe others as well. Practicing medicine, I think it's the best profession in the world. It gives you a lifetime of the opportunity to learn and to be helpful to others. You'll never be unemployed. Maybe one should never say never in medicine, but I think it's a true statement. You'll always be able to find work. You'll be able to put food on your table, gas or electricity into your car. I know that many of you have student loans. I'll touch on that, and that might influence how much money you have to do this and that. But medicine perpetually intellectually stimulating. New things are happening all the time, and those of you listening to me are going to contribute and have contributed to some of these new advances in medicine, medical school teaching, and so on. Erickson talked about these developmental life stages we all go through, and I think the last one involved generativity, meaning giving back. And I had the pleasure of dinner with the Bhatias, Dr. Bhatia, last night at the Star Indian restaurant in Omaha, and they, as well as all of you, even though you may not know it, have been exceedingly generative already. There's enormous self-satisfaction and occasional gratitude that you'll hear from your patients. There's still prestige in being a doctor. Medicine is still considered an esteemed and valued profession. I mentioned gratitude. I'm going to just quickly read this letter I got from the parents of a patient I treated for 2 years. Dear Dr. Perman, Mary and I want to thank you so much for all that you've done for Billy, not his real name, over the years. 14 years ago, we were in a suicide watch mode because we had no idea what was going on with our son. We just knew that he was very depressed in a dark place. Luckily, we found a psychiatrist. It wasn't me at the time, who diagnosed the OCD. We then began a long, twisting and turning journey of recovery and discovery. While art school, there's an art school in Washington, the Corcoran Art Gallery, that got a hold of my name, and they would sometimes send me some of their students that needed a psychiatric evaluation. It didn't result in Billy becoming a graphic designer. It did allow him to make the connection with you, which has played a crucial piece of his ending up where he is today. We always had a fantastic son, but now we have a happy, fantastic son and husband just starting his career. His OCD was so severe that when we first started, he avoided having people touch him. He was just extremely obsessive about that. And as things moved on, he met a young woman. They began dating, and it went on from there. Just starting his career, he is finally comfortable with himself and what he wants. It is such a pleasure to be around him and see him with his wife, brother, and sister. We can't thank you enough for the role you played in getting him to this point. He has been helped by many health professionals over the years, but you were clearly a major influence on him. Again, thanks. Signed by the patient's parent, father, and mother. So it's infrequent that we get a letter like that from anybody, thanking us for what we do, but I did have that one, so I thought I'd include it in this presentation today. So medicine is challenging, stressful at all stages of our career, medical student, resident, etc. It never ends. I find that at this stage in my career, I don't think of it being so stressful. We wear two hats. I wear two hats. On the one hand, I'm having conversations with my patients I see in psychotherapy, conversations, and some of them dealing with serious problems in their life. On the other hand, is the doctor hat that I wear too. So at the end of my day's over and I get on to the evening and I'm okay. But it is stressful still. We treat seriously ill patients. I think, especially those of you in internal medicine, all day long for years. Us psychiatrists too, but it's different. And we don't think about how day after day the stress of treating sick patients just builds up almost outside of our awareness, but it does accumulate. We often have high patient workloads and insufficient supervision. I could say, you tell me, you know more than I, but this is what I believe is happening. There is a sleep deprivation, especially with emergency room and ICU shifts, whatever specialty, clinical specialty you're in. There's often work-personal life imbalance. Okay, we never shed that physician persona that we have every day, all day, but part of taking care of ourselves is going to be to compartmentalize and to take care of ourselves. Student loans. I remember going to a grand rounds at George Washington one day, and somebody was speaking about the finances of medical education, and it showed a chart, and there were two lines on the chart, and one of them was for paying back student loans, and the other one was for the amount of money you'll make in a year. I think the money was the bottom one, the student loans was the top, and it was going to take a long time for them to meet. Hopefully that won't be your situation. We deal with managed care. You do, where managed care companies on the psychiatry service, especially inpatient service, there'll be calls every day where the psychiatrist has to justify getting one more day of treatment for their patient who needs it. It's time consuming. It's not pleasant to have to do that every day, but it is. There's malpractice insurance, the fact that you need to pay for this every year. It's just not inexpensive. If you're in practice by yourself, not an employee of Creighton, for example, overhead concerns, MOC, maintenance of board certification, maintenance of certification every 10 years. I put a question mark there because I've recently learned that there's another path one can take of reading articles for CME credits that can serve as a way to get continued board certification. And then I'll be talking about burnout shortly, give you a definition of that, speak about a relationship and family stresses, Some physicians fall into substance abuse, and then there's the risk of suicide being a physician. I'll just say one slide here about the coronavirus pandemic. Are there still repercussions from the pandemic? Since I've been to Creighton, I've been introduced to many lovely faculty, medical students, residents, fellows, and with about 3/4 of them, I show them my elbow rather than a handshake, because COVID is still out there. With others, I shake hands, but this is just an additional layer of stress. And do we wear masks or not when we're meeting with our patients? It's physically healthier that way to do so, but it does interfere with the relationship, that physician-patient relationship that you have with your patient. How much can you practice telemedicine? Certainly some specialties more than others. Yesterday, I gave a grand rounds to the Department of Psychiatry titled Psychodynamic Telepsychiatry After the Pandemic. After I prepared my PowerPoint for Creighton, I thought, why not turn it into an article? I submitted it to Psychiatric Times, this online psychiatric magazine. It was readily accepted, and yesterday it got uploaded to the internet. So if you Google Perman and psychodynamic telepsychiatry, you can read about that. And if you're doing any telemedicine, that could be useful to you. And Creighton gave me the opportunity to do that. I'm appreciative. The culture of medicine I'll speak to. One's personal identity is tied to the profession. 24/7, you're a doctor. I supervise a psychiatric resident, and rather than him presenting his usual case to me last week, he wanted to tell me an experience where he walked out of Whole Foods, which was a block from the George Washington University Medical Center Hospital, had his scrubs on. Maybe he had been in the ER that night, and somebody said, "Hey, doc, I think you should see this right near here." And there was a man who had died on the street of a fentanyl overdose. The psychiatrist went over to check his pulse, and he was dead. We talked about that, and it led to some other thoughts about maybe things that he and I could do, a project to decrease the likelihood of that happening in DC. But the point is, he thought he was just going to get his breakfast that morning at Whole Foods. And little did he know that he was still a physician and identified as such. Doctors have competition from PAs, nurse practitioners, and others. They all do good work. I'll say all as a profession, but so a lot of impingement on our ability and areas to practice once we finish training. We're all under the constant pressure to do more than we do. We fear being exposed as only human, which we are only human, but we're seen as semi-deities, slightly above that, still by some segment of the population. If we acknowledge that we have feelings about what we do, my God, I'm tired, so exhausted. We don't let the next patient know when we walk into their hospital room to be there for them and try to be of help to them. There is a fear and stigma by acknowledging mistakes. Sometimes I joke that being able to say, I don't know, is a developmental step that takes place when we're about 40 years old. Before then, we ham it up and jaw and say things, but just short of saying, I don't know. We don't want to admit that we don't know something. But I encourage you to allow yourself to say that if you don't know something. And we may add, but I know where I can find the answer. Uh, and we worry that if we're seeking help for ourselves, that others are going to want to keep their distance and shun us, seeing us as less than perfect. Must be something seriously the matter, and not wanting to say refer to us if we're on practice. So we worry about that taking place. Okay, now the definition of burnout, and burnout is short of impairment. Okay, and burnout is kind of a normal phenomena that we're all vulnerable to experiencing, and it's been defined as a syndrome resulting from chronic workplace stress that has not been successfully managed. And it has three dimensions. It can result in feelings of energy depletion or exhaustion, increased mental distance from one's job and one's patients. Okay. We'll focus more on the chart in front of us when we enter our patient's hospital room than look at and listen to what the patient has to say. The profession of scribes, as you all know, has sprung up, and this is a way that can get us back to paying more attention to our patients and listening to them when we meet with them. And then there can be increased negativism or cynicism about being a doctor, about seeing the patients, us becoming a bit more sarcastic with our colleagues and talking about patients that we've seen. A burnout is due to dysfunction in the workplace. It's not due to a lack of personal resilience. That is, any of us are vulnerable to the syndrome of burnout if we're put in certain situations. Some contributors to burnout include laws, regulations, and standards that we need to follow and keep up with. And some of them are lengthy, extremely specific, you know, with so-called healthcare reform and payment policies, especially through managed care. We're often asked to do more in less time, which creates problems. And we can ask ourselves, what is the limit of the least amount of time I can see a patient and still give that patient enough of what they need? Unanswered question. We need to keep up with our medical records, coding requirements. I remember I attended a grand rounds many years ago and was told to think that whatever I put in the medical record, imagine that I'm in a courtroom and it's blown up 100 times on a screen in front of a jury. So we want to think about what we want and need to put in our medical records when we're charting, but also think about what we don't want to put in that's not necessary, doesn't need to be there, will help maintain patient confidentiality. So we need to be thoughtful about that. There's quality measurements that we're all under. Sometimes we'll determine our promotion trajectory within a hospital system. Are we meeting enough of the quality expectations? There are reporting requirements. There's prescription monitoring of controlled substances. It's a big deal. It's out there. We need to attend to maintaining privacy and security in our communication with patients. Some of this I addressed yesterday in my grand rounds about psychodynamic telepsychiatry after the pandemic. There's prior authorization requirements some medical societies, including the one in DC, is mounting an offensive against these requirements for prior authorization with insurance companies that are so time consuming, and we need to convince the insurance companies almost more on the inpatient services than outpatient, that the patient is getting better all the time. Okay, we're making progress, but the patient is still sick enough that they need continued treatment. So there's a kind of balancing act that we do. I say that with a little bit of a smile, but it's quite serious, and we need to honestly do that. And then maintaining one's professional license, and then MOC, maintaining your certification every 10 years now. With professional liability and malpractice, you will get sued. Okay. Now, what I'll say is that so people have looked into this, they've done polls, studies, etc. So every physician will get sued at least once in your career. Okay. Now they say, never say never in medicine. Probably should never say always in medicine either. So I will say, even if you personally end up going through your career and never getting sued, the person sitting next to you will get sued twice. So the statistics will show that we all get sued if we stay in practice long enough. And then contributors to burnout, maintaining physician-patient relationship. It takes emotional energy, compartmentalization, so that patient thinks of him or herself or their self as the only person in the world, the only person in your practice. So when I'm meeting with my patients in psychotherapy, occasionally I'll slip and I'll refer to the fact that I have other patients. I think that wounds my patients deeply, because at some level they want to think, as we all would like to think, that we're the only one, burnout in medical school residency. So I have some references at the end of my slides that show that over 50% of medical students and residents, 50% medical students and residents experience the syndrome of burnout to some degree. It's due to demanding curriculum, time constraints, difficult learning climate, too much information, and it doesn't stop and just continues. Some of the new information replaces old information, but a lot of it just gets added on. So how do we possibly keep up? We do the best we can, can't keep up fully when you are in rounds and your attending is asking you and your fellow students or residents about the patient in room 501. That's the room I'm staying in at the Four Points Hotel in Omaha. In room 501, about the patient. Anytime anybody is asked a question by anybody, we feel at a deep level as if we're being challenged, questioned, even attacked. And we don't usually think about this. We just answer the best we can. But it's like if the person asking the question thought that I knew the answer, or was sure I knew the answer, he or she wouldn't have to ask me the question. So it's a grueling experience that is usually outside of our awareness, but it's taking place frequently all the time. There can be pessimism, negative self-perception of one's own health. We've heard of medical student-itis. I don't need to tell you about that. And impaired motivation to work and study. The mind might be willing, but the body is holding back and just not wanting to go ahead. So we push ourselves sometimes the best we can. That can result in exhaustion, depersonalization, am I human, professional dissatisfaction, and in the French culture, anguish is an important word. We usually think about anxiety, but anguish is a phrase in French, angoisse, that covers this sense of distress that we can sometimes have. Possible consequences, cheating, in different ways. On exams, we've been up all night. We need to write our chart notes. We didn't quite get some of the lab studies, but we know what they were yesterday and the day before. They were probably the same today. So we do that. The words WNL, we all know that as within normal limits, okay? It also stands for something else, which is we never looked. So we write down WNL, WNL, and the attending thinks we're writing within normal limits, but sometimes little do they know. Dishonest clinical behavior, depression as a consequence of burnout, substance abuse, and then suicidal ideation. One moment here. I'm going to get there. Okay, how to avoid burnout. Try to live in accordance with your internal values. Listen to yourself when yourself tells you, I need to step out. I need to take a 10-minute break now. All work and no play makes Jack or Jill a dull boy or a girl. That's an old saying and still holds true. I will say avoid drugs, excessive alcohol, risky behaviors. I don't think that marijuana or other recreational drugs do people well. It's a general statement. Some elderly patients in the last stages of a terminal illness, fine, let them get high. It can help mute some of their pain and take them out of their pain and their anguish, etc. That's fine. But to smoke pot regularly, I think if we were to divide the world's population into two groups, heavy pot smokers on the one hand and those who don't smoke pot at all, I would think that all other things being equal, that those who don't smoke pot probably have just a healthier, somewhat more productive life. So I'll say that. Reconnect with your environment, an antidote to excessive studying, treating sick and dying patients. In psychiatry, I tell my trainees that other people are an antidote to depression. Not always, we could think of exceptions to that idea, but connecting up with others and trying to put aside our devices for a while can be a good thing and an antidote to burnout. Maintain social and family supports, get enough sleep, eat a healthy diet, exercise, etc. I'm interested in all of that and try to practice it best I can. Of course, when I first get to know a psychiatric patient who comes to me, I will ask about sleep, among other things. And I like to get some numbers in psychiatry, so it's a little less touchy-feeling. And I'll say, what time do you go to sleep? What time do you wake up? And then tell me about your sleep through the night to get that. And in order to get a sense of whether the patient's getting enough sleep, finding out when they wake up and then counting back 8 hours is the time their light ideally should be shut off. And they may not sleep a full 8 hours, but it at least allows them the possibility to get 8 hours of sleep. Allow yourself to seek psychotherapy if you think that you're drowning, or even before you're drowning, to get a consultation. to get an idea, might this be helpful to you if you're experiencing some of these symptoms of burnout? You don't have to be drowning before you reach for a life preserver. Physician impairment beyond burnout. A definition of physician impairment: the loss of skill and the ability to practice medicine safely. 10% of physicians in surveys that have been done become impaired sometime. Alcohol use disorder. It used to be alcohol dependence, alcohol abuse in the DSM. Now it's AUD, alcohol use disorder, and then categorized from mild to moderate to severe. It exists among 10 to 14% of physicians where they drink excessively. I also divide the population into two groups: those who have 2 or more or less drinks at a time, and those who have 3 drinks and can keep going. So if it's a 3 or more at a time, in my view, there's a need for a greater conversation about that. 1 to 2% of physicians have substance use disorders. And then many physicians with impairment suffer from anxiety, depression, one end of the spectrum, dementia. They can suffer from psychosis, bipolar disorder, schizophrenia, and then have behavioral disorders, especially due to if they feel their narcissism is challenged, or they feel overly frustrated with scalpels flying in the OR, for example. Okay, here's a slide on suicide. 300 to 400 US physicians commit suicide a year. It used to be 400. I did some Googling to get my slides up to par last night for this presentation. So I came across 300 to 400 equals about 1 medical school class. I used to have, when I give my talk at Georgetown to the post-baccalaureates, I have the students stand up and look around and say, this is the number. It'd be half the number, because it'd be about 200 students in the class who will commit suicide each year of physicians. When one physician commits suicide, it can affect as many as 2,300 patients who they may not be seeing internal medicine weekly, maybe once every 3 months, et cetera. And it affects other MDs who need to step into the breach and take care of them, take care of their patients. And then firearms, the #1 method of suicide. And many people, including physicians who die of suicide, are never reported as having died of suicide. I had a best friend for 30 years who had been a psychiatric supervisor of mine when I was in residency. And over the 3 decades, we did a lot of things together. He had a sailboat license. We sailed many times. Later gave up the sailboat. He got a small plane, became a pilot. We would fly to nearby cities on towns on Sunday mornings and have our psychiatric study groups where we would supervise each other for our patients. And his wife, who had been a nephrologist for many years, developed breast cancer, treated, did well for the next 8 years. She died. My friend went into a deep depression, and eventually he went into a psychiatric hospital for 3 days, convinced the staff he was fine. 3 days later, he went home, and the one gun from his gun collection that other friends had not located, he used to shoot himself in the chest. I gave a eulogy at his memorial service, my good friend, and in the newspapers, his death was absolutely not reported as a suicide. So this number is most likely far greater than 300 to 400 a year. Male physicians, I won't get into the issue of transgender. I don't know if there's statistics on that now, but male physicians commit suicide 1.5 times more frequently than other men their age in the population. Women 4 times as much. We won't talk about possible reasons for that right now. 15 to 30% of medical students who have been evaluated test as being depressed. Suicide is the second most common cause of death among medical students, the first being accidents, in the late teen years, early 20s. And there's twice the incidence of suicidal ideation in a poll of 50,000 physicians and students, twice the incidence compared to age-matched controls. And suicide may be the presenting symptom of depression and burnout. Us doctors are often reluctant to get help for ourselves, and so suicide can be the presenting symptom. Keeping an eye on the time here, maybe finishing up in 5 to 7 minutes or so we'll have time for questions. When clinician suicide, when healers are mortally wounded, one's personal identity is tied to profession. For example, there were 2 psychiatrists, both in their 50s, being investigated by Medicaid, and they felt stressed, wronged, and killed themselves by guns. Burnout has been found in recent studies in 50% of critical care, emergency room, and family medicine physicians, and 38% of psychiatrists. It's a major contributor to suicide. Suicide prevention, maintain connection to family and friends, have hobbies you engage in, lead a healthy lifestyle, feeling helpful to patients. None of this new to you, but I think it's good to hear it again. Symptoms of depression during one's first year of internship, there's a classic curve that goes down as you get into November, December, January, February, and then does rise again as you get toward the end of your first year. A deadly misperception is that seeking help is a sign of weakness among physicians. Access. 1 out of 5 residency programs in a national survey had at least 1 death by overdose. Anesthesiologists use IV fentanyl and propofol. Depression plus lack of sufficient knowledge about the lethality of what they're doing, plus access equals death. Psychiatrists get in trouble with boundary violations. 7% men, 3% women psychiatrists. That's one of the good things about telepsychiatry. You cannot physically or sexually abuse your patients. It's impossible, or vice versa. Internists, interventionists, surgeons will often treat or prescribe for their self, their family, and friends. It's rampant. And you all know what they say. A doctor who treats himself as a fool for a patient. Clues to potential problems, illegible chart notes. In this day and age, when everything is typed in, maybe if the notes don't make complete sense, that would be a clue. Rounding in the inpatient service at 3 a.m., working 24/7 without being scheduled to do so could be a potential clue. Falling asleep at work and at social events, and then problems with anger management. Reasons why physicians do not report colleagues. In a survey of 3,000 physicians, 17% knew of an impaired colleague. 67% of these, 17% reported the colleague. Conclusion, most physicians support the idea, the commitment to report, but many do not, saying someone else will do it. I'm afraid of retribution. What does it matter? Nothing will happen if I do report. Okay, so briefly, the Physician Health Committee of Washington, D.C., every state in the United States, maybe except California, that dissolved their Physician Health Committee, a couple of years ago. I don't know if they have something else in place now, has a physician health committee, at least one. And we have about 10 members on the DC Medical Society Physician Health Committee. Our mission is to evaluate, refer, and monitor. We don't treat physicians who come to us, but we evaluate, refer, and monitor. And we encourage the physician to engage in a 5-year contract with us. And the contract states that if you agree to do this, that, and the other that we recommend, we will advocate for you, which often allows the physician to continue to work or to get back to work after a period of being away from work. And the things that we require may include a physical examination, independent outpatient and or residential treatment evaluation. Some of these physicians go into an inpatient treatment program for up to 3 months, depending on the issues. And it could include the contract individual and couple psychotherapy, attending 12-step meetings, including physician or caduceus meetings, getting random urines or hair testing done, and meeting with their monitor and our committee every so often. It's all on Zoom now. So, wrong one. Oh, it worked. Okay. Let me see here. What I'd like to do, I'm going to skip some of these vignettes. This is not advancing. Well, maybe the wrong one here. Great. Skip that vignette. Dr. Richards. Outcomes, 75 to 90% of physicians we monitor remain in or return to work. 70% remain drug-free since the initial evaluation. 18% relapse once. 12 more than once before full abstinent. There was an article in Time magazine. I don't see the date of this. It wasn't too long ago, where a physician impairment, a burnout, and stress was described. So the public is becoming aware. Then I have some references if you want them. I'm sure that Dr. Ranga can get them to you. Thank you all for your attention, and time for questions and comments, and end of slideshow. I'll just go back to that one. So go ahead, Jessica Seaman, and open it up for back and forth with myself, and I'll take all questions and comments.
Thank you so much, Dr. Perman, for such an important and timely session. We appreciate all the information you've given us, and important to know a lot of that data that you shared with us as well. First question in the chat says, why not present patient protection guardrails as positive mechanisms to be an active participant in the advocacy team rather than presenting them as threats?
Yeah. Patient protection guardrails. If we can, give me let me hear 30 seconds if the person would unmute and just tell me what is being meant by that. Yeah, can we do that?
Yes, anybody can unmute. Linda, do you want to give any?
I could speak in a general way, which is saying that we all want our patients to do as much as they can for themselves. In fact, one maxim in psychiatry, maybe even in life, is to do for others what they cannot do for themselves, and don't do what they can do for themselves. And also, I tell my psychiatric patients these days that as a psychiatrist, I don't help anybody. I help my patients help themselves. That's what I do. So I would include the patient in this. Importantly, we all take our own advice better than we take advice from others. So if we can get the patients actively involved, I fully support the intent of the questioner, if I heard it right.
Okay. I'll go ahead and speak. I'm Dr. Linda Lejour, Associate Professor Emeritus I'm Dr. Linda Lejour, Associate Professor Emeritus from the College of Nursing. And I was looking at how the contributors to burnout were presented. It seemed like they were very negative. And I think if one can present those as, yes, they're realistic, they're here, but put them in more positive light when med students and other healthcare providers hear them, instead of having them be threats to one's practice, they could be opportunities to really be a team member with the patient, as the patient is trying to be as healthy as possible.
I appreciate that, and I will take that to heart and see what I can do going forward from here. And thank you. Yes. Okay.
Thank you, Dr. Lejour, for some context there. From Dr. Bremner, he says, what role do you see peer support groups and coaching in our work to counteract burnout? If these have a role, how do we make them more culturally acceptable?
Great. If I put my hands to my ears, it doesn't necessarily mean that I don't hear you. I just want to optimize and hear you better. So just to let you know that, I think that to some extent that falls under the rubric of other people in your lives, and how relationships with others are the antidote to feelings of being alone, all alone, and burning out. So I fully support seeking out whatever opportunities we have to interact with others. I think coaching can do that. Being a part of groups, enormously important, so I fully support what was said in that question. Yeah.
I wonder too, if Dr. Perman, that having groups before somebody actually is going to need them and coaching before they need them might help with the culture of feeling like we can mentor each other, we can coach each other for when the time comes.
Yeah, let me say something. So I'm here not only to try to teach something or other while I'm at Creighton for 3 days, but also to learn. It's a tremendous opportunity for me. And not only did I meet Dr. Johnson yesterday for an hour with Dr. Ranga, a director of diversity, but so I heard about efforts in that direction. But I also heard there was a student, either a student or a resident in the Creighton Department of Psychiatry training program, whose role is to pay attention to the social life of the medical students and residents. So I think that's what we're talking about. So they're being looked after here. I haven't come across that at GW. It's a great East Coast institution, but I find it in Nebraska, in Omaha, at Creighton University Medical School. So, yeah.
And we are trying to do that in Phoenix as well. And they have really done a big push with our M1s, our first year students this year, for that social aspect. So we are noticing a difference for that. Thank you.
That's great at your sister institution there in Phoenix.
Yeah. We've got another question by Dr. Lenz. What structural changes do you see are most important to modify within the healthcare system?
Yeah, structural changes. I won't get into my interest in Jacques Lacan today, who has a great interest in language and how words relate to other words. But when I hear the word structural, I think about the structural racism, for example, and Dr. Ron Johnson's role. And structural changes are going to start at the bottom with people making their voices heard about what they think, what they see, hear, feel, smell, touch, that needs to be done and needs to be changed. So the word "what" was in the question. What structural changes do I think needs to take place? It's above my pay grade. Since I'm over 40 years old, I can say I don't know, and I'll say that. But I did share some thoughts that your question provoked. I hope that was sufficient.
Thank you for that. Another question is, I'm a huge advocate of therapeutic TTRPG for peer support and recommend their use. Do you have any thoughts on that?
Well, you'll have to tell me what RPG stands for, and then we'll go from there. And even my asking that is just hopefully a lesson in there. Anytime you're asked something and you don't know anything about part of what was asked, don't hesitate to ask the question. And maybe I'm not even the only person in the audience who knows what RPG is. Maybe you all know, but what is RPG, Dr. Seaman?
I'm going to have the questioner themselves. Can you do that and give us some context? Maybe not.
How about anybody? So I bet somebody knows what RPG stands for. I could try to guess, but somebody unmute themselves, just shout it out.
Here we go. She put tabletop therapeutic role playing games. So doing role playing, tabletop therapeutic role playing.
Sure. Not knowledgeable about the specific aspects of therapeutic role playing. I think anything that will enhance our ability to be empathic with what our patients are experiencing is a good thing. Now, maybe even the word anything, that could be too broad, but many things that we could do to put ourselves in the patient's shoes, including role playing, sounds like a really good idea to me. Yeah.
Thank you for bringing that up, Michelle. That's something sounds like a lot of us need to know about as well. Anyone want to unmute themselves? I think we got to all the questions that were typed in the chat, but if anybody wanted to ask a live question, you are welcome to do so as well.
And I would encourage you, I've done this with some of the residents I met with so far. If you're thinking to yourself, should I ask this or should I not? Ask the question, be brave, be bold, put yourself out there. This is Nebraska. You guys got some strong character and personalities here. I want to see some of that.
Well, it's bringing us to the top of the hour, so I feel like we were able to answer all the questions that were asked. I appreciate, Dr. Perman, your sense of wanting to learn as well. I think that is hugely important when you have been in practice for so long, but also wanting to learn things. And I see lots of comments about thank you for the presentation, great presentation. Appreciate the patient-centered approach that you were talking about, and really the learner approach too, right?
Thank you, Ms. Seaman. Thank you for Joe Ranga for inviting me to Creighton. It's been a wonderful experience. It's 3 days here in Omaha and at Creighton, and I'm going to be continuing to stay in touch with Joe for the next year as part of my role as a Teichner Scholar. And have a good day. Allow yourself to have some fun. Stay with that 2 drinks or less if you can manage that when you go out. I think that's a good rule of thumb. And maybe we'll meet again. Thank you.
Thank you, Dr. Perman.